Thank you. I would like to thank the organizing committee for inviting me to give a speech and a lecture in this session. Actually, when I looked at the title of the talk, Success Criteria for After a Mitral Clip, if we will look at the literature, what we will find is this, the acute post-procedural success. We don't have one single article regarding the success criteria. But what we will do now, I will just share with you the definition of acute post-procedural success is defined by a resulting residual MR severity 2+ or less, and at 30 days. And of course, if we don't have immediately, it's considered at 30 days. Now, what we will be discussing is pretty much common with what have been previously and beautifully discussed with the previous speakers. So I would like to start with this. This is, I know everybody is familiar, but to understand the geometry of the left ventricle and why we will have failure, we have to look at this. Our mitral regurgitation is the imbalance between closing forces and tethering forces. The more dilated your LV is, and the more weak your LV is, and that I can speak with passion about because advanced heart failure is my field, the less likely your patient will benefit from mitral clip repair. I have to re-show these studies because it all started there. If we will look at the Everest trial as a failure, I think we are mistaken. Let's quickly summarize what it was all about. The inclusion criteria, more than LVEF, more than 25, less than 60%, and systolic diameters between 40 and 55 millimeters, and the exclusion criteria, mitral stenosis, recent MI, and or mediastinal surgery. So what was the acute post-procedural success? It was 74%, which means in 74% of the cases, we were able to avoid surgery. The primary endpoint was not met, but as we can see here, we had less major adverse events, significantly less major adverse events with mitral clip compared to the surgery. Now, the most successful trial with mitral clip is the COAPT trial. The inclusion criteria, of course, they improved. They learned from the MITRA FR, and the inclusion criteria included the LV dimensions. Of course, the LV was less dilated. It was less than 70 millimeter, ejection fraction between 20 and 50%, moderate to severe secondary mitral regurgitation, NIHA 2 to 4, despite guideline-directed medical therapy. And now, what about the diameters? I'll just show you, share with you that mean left ventricle and diastolic dimension. It was 6.2, which means dilated, but not extremely dilated. And most of the patients were in class NIA, New York Heart Association 2 or 3. What are the results? As we can see, we have lots of zeros to the right. We are very happy. It's a very successful trial. The primary endpoint was met. The primary endpoint was heart failure hospitalization. The secondary endpoint was met, mortality, death from heart failure or from cardiac cause or from any cause were significantly less in the arm device, mitral clip, compared to control, which was medical therapy alone. Again, it's pretty much the same thing, but what I would like to show here, and even the going to LVAD or heart transplant LVAD alone was significantly less in the mitral clip arm. So when we carefully selected those patients, we could delay the stage of advanced heart failure or stage D heart failure. Now, what about the quality of life? We always look at mortality, we always look at heart failure hospitalization, we always look at freedom from surgery. But quality of life is as important as the other outcomes, especially for elderly patients. Improving their quality of life and their functional status might be as important as improving their survival. And as we saw here in the co-opted trial, there were a significant improvement in the quality of life. And I would like to use this quote: sometimes it doesn't matter to add year to your lives, it matters to add life to your years. Now I will share with you the expanded trial, which is the biggest real-life trial on mitral clip. Largest contemporary real-world all-comer study. It's a single-arm, multi-center study, including patient with the selection criteria were here. So it's a prospective trial, multicentric, studying the outcome of these patients. As we can see here, this is beautifully shown that 89% of success at 1 year. 89% of success, meaning mitral regurg 0 or 1, not even 2 or 2 plus. Because if we will add 8.3, we will reach more than 90% of success at 1 year. The acute procedural success is 97%. It was 95% with the co-op trial, which means with the time, with the improvement in the selection criteria, with the improvement in the implantation technique and improvement in the technology in itself and the learning curve, we are reaching really very, very encouraging level and a high level of success. As per the EXPAND trial as well, we have significant improvement in the LV dimensions, LV and diastolic diameter, and the dimensions and annulus of the mitral valve. We also have significant improvement in the volumes of the left ventricle, whether end-diastolic or end-systolic. Now, I will not discuss this. It was beautifully discussed with the experts, but just to show that we should select carefully our patients, select the best device to the best patient according to the data we have. A small comparison between the studies. Of course, MITRA-FR, we all know it was not a successful trial. It included as primary endpoint death and heart failure. The COAPT included heart failure hospitalization. COAPT included heart failure hospitalization, but also the death was significantly lower in the COAPT trial. The criteria were more carefully selected. LV and systolic diameter below 70 millimeter, which is pretty much dilated as well. Ejection fraction between 20 and 50%, and NIA class 2 to 4. The reshape is ongoing. The primary endpoint in MITRA-FR and COAPT also were similar except for the death. The exclusion criteria were different, mainly in terms of LV dimensions and in terms of RV. The MITRA-FR did not exclude any patient based on his RV function. COAPT trial excluded patients with RV right-sided heart failure, patients with severe pulmonary hypertension. So now we have a failure. What's next? What's next? Let's start by seeing what we have about surgery post-failed mitral clip. We have the concern of the difficult repair post-mitral clip due to what we know about the fibrosis induced by the clip in itself. Well, mitral valve surgical repair is feasible in most of the cases, and despite that the population of patients that are considered as very high risk for the surgery, the outcome post-surgery for failed mitral clip is very good. And this study was done on 25 patients with failed mitral clip out of 1,204 patients. What are the other options? Mitral clip. Of course, we can also have the possibility of redo mitral clip post-first mitral clip procedure. This study published in ESC, heart failure, included patients with severe or moderate to severe functional MR following mitral clip with NIA 2 to 4 and reduced LV function. We can see here that the redo procedure, the success rate, although it was 100% in the first procedure, it now dropped to 65% in the second procedure. It's feasible, but the success rate is lower. And we know why. We can expect the success rate to be lower because these patients, whether they are an advanced heart failure or what was difficult the first time will be more difficult the second time. Now, I would like mostly to end by this beautiful chart from the ESC 2021. When we have a patient with secondary mitral regurgitation and heart failure, we need a multidisciplinary team approach. The patient should be on guideline-directed medical therapy. We should discuss the possibility of any surgical intervention, the possibility of CRT, and, of course, when we have this mitral regurgitation eligible according to the data we have eligible to repair, we should go for percutaneous repair of the mitral valve. Here we can see what's important in this is when we judge our patient high risk for surgery and an end-stage heart failure, we should not go for mitral clip. If he's high risk for surgery, if he's advanced heart failure, we should go for LVAD or heart transplant immediately and not waste our time with the mitral clip because he will recur or he will not benefit. I will not discuss this. These are the most updated criteria for the severity. If we want to be competent, we have to follow also the data. It's pretty much the same thing, whether ESC or ASE or AHA-ACC. In conclusion, the success rate of mitral clip has increased tremendously through the last decade. Why? Because of the improvement in the technology in itself, because of better selection of patients, and if we will look what will be our success criteria, of course we have the acute success of the procedure, we have the decrease in heart failure hospitalization, cardiovascular death, quality of life and functional capacity, residual MR severity, LV dimensions, and freedom from surgery. I would like to finish with this French saying, l'absence de preuve n'est pas preuve de l'absence, which means absence of proof is not proof of absence. Thank you.